Okay, here we are at week 12. Oh my gosh, we are getting close. There is one more lecture after this, and then we will be done with lectures in radiology. Abnormalities of teeth. This seems pretty long. There's 74 slides, but there's a lot of pictures. So it's actually not as bad as it seems from just looking. So we'll see how long it takes to get through. Objective. Students should be able to recognize and record dental abnormalities relating to tooth number, size, shape, structure, and eruption on a radiograph. So these are all abnormalities you might see on a radiograph. Categories of abnormalities: defects or alterations in the number of teeth, the size of teeth, the shape of the tooth, the structure of the tooth, the eruption pattern or lack thereof, and then miscellaneous. Okay, so some key terms and then some pictures. So we have anodontia, which is the absence of teeth, hypodontia or oligodontia, which is partial anodontia, so partially missing a few teeth, one or several, but not all teeth are missing. Most common is third molars. So some people might have one third molar, or maybe they have no third molars. It just kind of depends. My husband has one impacted third molar, and he doesn't have the other three, or just missing. Followed by maxillary lateral incisors and then premolars. So those are the most common that are going to be missing. If premolars are missing, very oftentimes you will see a retained primary molar, or we'll call it an ankylosed primary molar, because oftentimes it is like ankylosed into the bone. It's like fused with the bone, basically. So here's a intraoral image of partially missing teeth. These are all baby teeth on either side. You can see how much wear, but he never, or she never had their primary mandibular central incisors. And then here are their maxillary permanent molars have come in, but so far nothing has popped through. So I don't know if they have their permanent, but I think they would have been through by now, because those usually come up pretty fast. So here is a radiograph of a retained primary molar. So as you remember, the molars, the baby molars, are replaced by the premolars. Oh, I have my pointer going in the wrong place. So here is the baby molar, and you would see a premolar would have come up through, but they did not have this premolar, and so they've retained this. And a lot of times I have seen patients, whereas if they care for their dentition really well, if they brush and floss, even though these roots are super tiny, they can be ankylosed into the bone, and they can retain these for decades. I've seen people in their 40s with a retained baby tooth. They do tend to wear down though over time, and this one has a huge filling, so a lot of times they may end up needing an implant to replace it. So here's a pano where you can see there are no, this might be that picture of that, the intraoral one from earlier, but here you can see there are no central incisors down there at all. And these are canines, so there's no laterals or centrals down there. Here is another image of a retained baby primary molar. So there's got some bone loss happening on either side though, but still these roots that are in there may be ankylosed in, so it could be still in there pretty good. So defects in number of teeth continued. So hyperdontia would be the opposite, And from hypodontia, hyperdontia is one or more extra teeth. We also call that supernumerary teeth, or if it's in the maxilla between the central incisors or at the midline, we call it maxillary mesiodens, which is an extra teeth in the maxillary midline. But a lot of times when you see, you'll hear most common if you see extra teeth, they'll refer to them as supernumerary teeth. So 90% occurs in the maxilla, but it can happen in the mandible as well. And here's a perfect example of a mandibular extra premolar, kind of funny shaped premolar, but this is an extra premolar in the mandible. Here you can see there's two extra premolars in the mandible. They've popped through on the lingual surface. And then here is kind of fun. Let's count these. So here we can see this is a canine, because see how it's kind of pointy. Here is a canine over here. Let's count the central incisors. 1, 2, 3, 4, 5. Oh no! I jumped ahead. So we have 5 incisors. I don't know what's... Yeah, I don't know if you've got extra they must have maybe, I don't know if they have an extra central or an extra lateral, but however you shake it out, they got 5 incisors, and we really only are supposed to have 4, so they have an extra one down there. Here's another mandibular supernumerary premolar. Here's a whole bunch of supernumerary teeth popping all over the place. You can see that it seems to be predominantly in the premolar area. Here's another little extra one popping through here between the lateral and the canine. Here's a mesiodens, so it's like a little tooth in between the central incisors, right in here. Here's a little baby molar behind this molar. So this is basically where the wisdom teeth, because they're missing the first molar that would have been here, and this is the second molar, so this is like a little baby wisdom tooth. And then there's another little extra tooth here in between the lateral and the canine. Here's a I think they have disclosing solution on their teeth. I think that's what all these dark edges are. But there's another mesiodens, so right in between the central incisors. So defects in size. So we have macrodontia and microdontia. Kind of self-explanatory. Macro is going to be teeth that are larger than normal. Micro is going to be teeth that are smaller than normal. And our most common microdontia is a peg lateral. So the maxillary lateral incisors, and they are kind of shaped like a peg. So they're kind of tapered a little bit toward the incisal edge, and they're much smaller than normal. So that's why they call them peg laterals. This is a picture of a macrodontia. So here's a lateral incisor that's quite large, almost looks more like the size of a central incisor. So that's a macrodontia lateral incisor. Here's a peg lateral. You can see it kind of looks like a little peg. And then their other lateral is pretty normal shaped or normal sized, but this one's the peg lateral. Alterations in tooth shape. So we have fusion. These are the terms that when you get tested on them, like if they're on a quiz or on the final, these are the ones that can kind of trip people up a little bit. So you want to really kind of study these terms. Fusion is the union of two adjacent tooth buds by dentin and or enamel. And then gemination is the aborted attempt by a single tooth bud to divide, the twinning. So they wanted to be two, they wanted trying to divide into 2 teeth, but they gave up and it never happened. Concrescence is the union between the roots of 2 or more teeth by just the cementum only. So concrescence happens just at the roots. So fusion is the union of 2 adjacent tooth buds. Gemination is the aborted attempt to divide into more than one tooth. So the tip here that you really got to think about is and when you look at in the mouth, sometimes it's hard to tell on the radiographs, I'll admit, because if you can't see enough teeth, it's hard to know what you're counting. But in the mouth, for sure, count the teeth. If there are too many teeth, if you're seeing too many areas that look like cusps and broken down into like incisal edges, and you're counting it up and you're like, that's too many, then that's gemination. And then if you're seeing just like really large teeth and there's not enough teeth, like say there's only 3 mandibular incisors, but one of them is really big, then that's fusion. So here's an example of fusion, because we have 1, 2, I think this is a canine. So we have 1, 2, 3 incisors on the mandible, but this one's really big. So this is fusion. And then here, if we were counting and we weren't really paying close attention, we might count this as 2 teeth. So we might think there's more teeth there, but you can see how this tooth was trying to divide into 2 and it gave up and just stayed 1. So this is gemination. Down here in the oral cavity, we see here's the canine here. The other canine is over here, and we have 1, 2, 3 incisors, but this one's really big. So this is fusion. So these 2 incisors fuse together. Gemination, if we count, if we're kind of thinking that we're counting these as 1, 2, 3, 4, 4, then, I don't think anyone would actually count those as 4, but you can see what I mean. There's the correct number of teeth are here between the canines. We have our laterals and we have our centrals, but it looks like these are trying to divide into more than 1 tooth. So that's how we can tell it's gemination. Here we can tell looks like this tooth was trying to divide, so that's another example of gemination. This one as well, you can see it was trying to divide into 2. And then here we have another example of fusion. So from canine to canine, we just have 3 incisors, and this one's bigger. So that's an example of fusion. Here's a picture of concrescence of 2 separate teeth that are fused in the root area. And then here's what it looked like on the on a radiograph. So the roots kind of just look like they're sort of entwined around each other. They're kind of, entwined around each other. Alterations in tooth shape. So we have dilaceration. That is a bendy, twisty, wavy root. Tooth usually as a result of trauma during formation and or eruption. Taurodontism. Tauro means bull, and this refers to teeth that have abnormally large pulp chambers and then kind of a short, kind of spread out looking root. Then there's supernumerary roots, which you can imagine is more than the expected number of roots. And then most common for supernumerary roots is in mandibular premolars and canines having 2 roots instead of 1. So here's dilaceration. You see these roots kind of kick out at the apex, or this one is super bendy. It looks like it's taken a walk. So these are really bendy, wavy roots. Here's another example of dilaceration. This makes it very difficult to extract a tooth and to do a root canal. Just imagine how difficult it would be to get all of that root canal cleaned out. You can see it looks like they perforated the root at the end here, and it looks like there's some pathology happening down at the apex because they couldn't really get a complete root canal there. The same thing would happen with this wavy guy. How in the world would you ever get that part of the root cleaned out? It's like an S shape, so it's really difficult. Here we have a supernumerary root. You can see this is a mandibular root with the 2 mesial and distal roots, and then down in between we have a third root that you would see like on the maxilla, but this is on the mandible. So there's a supernumerary root on this mandibular molar, and then here they're kind of superimposed over each other, but you can see there's two roots on this, I think this is a canine. So on this canine there's two roots there. You can see here and here and here. Here's a funny looking guy. It looks like he's like a tadpole or something, but this is looks like a canine with multiple roots. There's like 3. This is kind of crazy. There's something that's like a very odd looking tooth. Bifurcated root on a second premolar. So here we go again. So here's two roots on a maxillary second premolar. This is that same picture from earlier. It showed up again, the one with the root in the center and the bifurcated canine. Taurodontism. So here is that I don't know what I'm trying to say. That situation where there's an extra large pulp chamber, and down at the apex, instead of sort of being nice and tapered, it's kind of broad and flat, and it's just a very odd shape. Not much, not at all like a apex that you would accept or expect to see. It's just kind of broad and flattened, and the whole pulp chamber, especially down toward the apex, is quite large. Here is a bifurcated root on this canine, I think is what we're looking at right here, right up through there. It's kind of hard to see. That one was tricky. At first I was like, what are we looking at here? I don't know. But it's looks like it's bifurcated right up there at the apex. Some other, oh, you know what this could also have? This could be another abnormality too. This could be from this next slide. So a couple alterations in tooth shape. Enamel pearls, they are small, round radiopacities seen at the cervical portion of the root. So an enamel pearl is some sort of misplaced enamel, and it very oftentimes it's in a furcation. It can be sort of just right below the CEJ on the outside of the tooth. So it can be in different places, but it's usually sort of oval or round shape. Pulp stones are well-defined radiopacities in the pulp chamber. No clinical significance, except it would make it very difficult to do a really thorough root canal on a tooth with a pulp stone. Dens oh my gosh, I didn't say this out loud, I said it in my head, invaginatus or dens in dente. That results, it's a result of an infolding of the tooth surface before calcification. So it kind of almost looks like a dens in dente is tooth. I think it's like Latin or something, I don't know, which basically means tooth within a tooth. It's most often in permanent lateral incisors, 1 to 5% of the population, and it usually oftentimes it will occur bilaterally. So the other dens word is the dens evaginatus. I'm butchering that. Leonge's premolar, and that is a result of the outfolding of the enamel organ on the occlusal surface of premolar teeth. So those are other little tricky ones. So let's look at some pictures of those. So here is an enamel pearl. So some enamel that's deposited down on the root surface right in the furcation. And you'll feel as you're scaling along, if somebody happened to have periodontal disease and bone loss all the way down to this level, this would feel very strange. You'd go over it and over it and over it and over it, and nothing would change. Your instrument would dull, and you just think, what the heck is that? But if you took an x-ray of it and you had a good, sort of a good angle of it, you would see that it would be much smoother and rounder than calculus, and probably more radiopaque than calculus as well. So here's another example of enamel pearl. Look how rounded that is. If you guys remember back to looking at your, when we've been looking at calculus on x-rays, it looks more like a kind of a pointy spur. This looks very smooth and round, has very defined edges. Calculus really never looks like that, and looks very round here as well in this radiograph. Here is a enamel pearl in the furcation. It's kind of a straight-on image, so it's not as obvious, but you can sort of see how it's more radiopaque right there in the pulp chamber. Here's a pulp stone. It kind of looks like it's floating in the pulp chamber, so that is a lot more obvious than a enamel pearl because it's right in this radiolucent air part of the tooth, and then it just kind of looks like it's floating there in the pulp chamber. So this is, you can't really tell the den indente of this lateral. However, you'll see in the next image, it's causing some pathology. And this right here is a little fistula, which is like a drainage point for the abscess that is happening with this tooth. And so it's like a little pressure relief valve where pus and infection drains out. So if we look at the X-ray, we can see that it's like almost like a tooth within a tooth, but look at how much bone loss and how much abscess is happening around at the apex of this tooth, and that is what's draining out right here. So this is all bone loss and infection, and then it's found its path of least resistance to work its way out of the bone and then out to the outside world. So that's what's happening there. Here is another clinical image of den indente, or I thought it was dens indente. Anyways, and you can see it's kind of like a tooth and a tooth within a tooth, sort of. And then, oh, this is that image from before. So that is what this is the dens indente is here. You can sort of see how this area is more radiopaque. You can kind of see a secondary circular image here that lets you know that there's something extra has formed there. So that's what this image is. So then we have the dens evaginatus, and that is where the enamel has sort of outfolded. So the dens indente is where it has sort of infolded in on itself, and you have kind of like enamel structure and everything kind of inside the tooth, which is that tooth in the tooth. But this is where everything is kind of pooched out, and it's made this kind of almost like this central cusp in the center of the premolar, where because the enamel has sort of built itself up and out, sort of, it's like an outfolding of the enamel organ on the occlusal surface. So here is another image. You can see it's really defined right here. It's just like this little pokey out part in the center of the premolar. Here you can see it on the X-ray. So it's just this outfolding of the enamel organ in a place where you just normally would be seeing like a groove of the tooth. You'd see the, some kind of the pits and fissures and transverse grooves, but here you see this kind of outfolding, which is kind of an odd sight for that tooth. Alterations in tooth structure. We have root resorption. You can have two different kinds of root resorption. You'll have external root resorption. It's caused by chronic periapical or periodontal infections, pressure from tumors or cysts, rapid orthodontic movement, or they don't know why. Things will just, your body, it's almost seems autoimmune. Sometimes it's like just something's going on and your body just, the roots just start resorbing, and sometimes there is no known cause. But there are situations where they know what's happening. Sometimes when a tooth has had a root canal, it will have some root resorption. as well. There's also internal root resorption, which that they really don't know what triggers that, and that almost seems to be that kind of almost like an autoimmune. Your body just starts kind of eating itself, and it's not, the dentists are not sure what is causing it. You'll learn more about this in oral pathology when you take it over the summer with Kathy, if hopefully she's still teaching it. She's been teaching that for a while. Let's see here. So here's some pictures of external root resorption. This looks to me like ortho, because see how it's happening on all, it's not just happening on one. So in orthodontics, if the teeth are moved too quickly and there's too much pressure too fast, then this can happen. The roots can start to resorb. So that is iatrogenic, meaning it happened because of something that the dentist did instead of just some anomaly in the mouth. So that could have been prevented if they had not moved the teeth as quickly with the ortho. But it can happen with other reasons, but that's what it looks like to me. Internal resorption, you can see here's the pulp chamber is just getting really huge, and soon it's going to break its way right out of the side of the tooth, and it'll seem like a cavity, but then when they take an x-ray, they'll see that it's internal resorption, and really there's not much you can do. Sometimes if the tooth has not had a root canal, they will do a root canal in attempts to stop the resorption. Sometimes that works, sometimes it doesn't. Sometimes they just have to extract the tooth and it has to get replaced with an implant. Abnormalities in eruption. So impacted teeth. Some physical entity has prevented eruption. Mandibular and maxillary third molars is the most common, and a lot of times it's because we just don't have space in our jaws. Bony impaction, partially or completely covered by bone. Soft tissue impaction, covered only by soft tissue. Transposition, a tooth eruption in the normal position of a different tooth. So let's say that one again. Transposition, a tooth eruption in the normal position, but it's a different tooth. So it's a tooth that you wouldn't expect to come up in that area. So here this canine is impacted. You see canines are probably the next most common, I would sort of guess. At least in my career, that's what I've seen the most be impacted besides third molars is canines. But here this canine is kind of going a little bit sideways. You can see these third molars are going off in different directions. This one's has sort of a partial bony impaction, and that one is kind of coming in this way. That one's going more off distally. This is a soft tissue impaction. It's just kind of covered. The bone is pretty much gone out off the top, but it's just the soft tissue that's covering it there. That was a wisdom tooth as well. This guy's a wisdom tooth. Impacted canines again. Those are quite impacted. Those can pretty easily be open. Anyone who, probably people in our class have had this experience where they go in and they attach a bracket and then they just they guide them down and pull them down where they're supposed to be. That orthodontists do that all the time. And then here's transposition. So it's a tooth that wants to come up sort of in the right place, but it's the wrong tooth. So this it looks like a canine to me, and it's trying to come up in the area of the central incisors. And it looks like it's causing some root damage there, so that's a problem. Acquired dental anomalies. We have attrition, and we talked a little bit about this in our previous lecture. So attrition, abrasion, and erosion. Attrition is normal physiological wear resulting from just normal function. Abrasion, abnormal non-physical wear caused by foreign substances or excessive habits. Erosion is damage to tooth and enamel involving chemical action that's not bacterial. So let's see some images. So here we have attrition. This is just, you can see just flattening out, wear, just heavy grinding, severe, grinding and clenching habits. some more images of attrition. Pretty much when you see this, but if there is a scooping at all, then you can be very suspicious of acid erosion as well. It can be twofold. It can be attrition and acid erosion. They can have a double whammy. So if you see any kind of scooping, that's a telltale sign of erosion. So here's abrasion up at the cervical part. Again, we talked about this a little bit before too. This is most often attributed to toothbrush abrasion, but it can also have to do with clenching and grinding habits that put pressure at the weakest area, which is at, basically right at the gum line. And so little microscopic bits of the tooth structure right there at the gum line can flake off just over time, and it can also cause this abrasion. Erosion, you can see it's real smooth, a little bit ditched out on the lingual surfaces. If that's super telltale sign of either chronic GERD or that acid reflux, or maybe repetitive vomiting as well. Oops. Here's what erosion would look like on a radiograph. Very radiolucent right through there, kind of smooth looking radiolucent. And there's the same picture again. So here's a question for you. This patient is a 20-year-old dental hygiene student and a daughter of an orthodontist. Which anomaly or anomalies is or are present in the lateral incisor? So here's the lateral incisor. Dens in dente. It is dens in dente. I kept wanting to say dens. Dens in dente. Dens evaginatus. Orthodontic root resorption. A, B, and C, or A and C. What do you think? Give you 2 more seconds. If you said out loud dens in dente and orthodontic root resorption, so A and C, you were right. Congratulations. Non-tooth related miscellaneous. Mandibular tori, you will see this you'll see this clinically, of course, in your patient's mouth, and you'll struggle with your mandibular x-rays or if they have maxillary tori, to take your films around these. I know it can be very challenging, depends on how big their tori is. Mandibular tori or maxillary torus or maxillary buccal exostosis, it is all just bony growth, and it's just attributed oftentimes to heavy bruxing and clenching. It usually just gets bigger over time. It's not dangerous or really can affect their anything about their oral health. It's just, it can be annoying. They can grow so big that they get in the way of eating and talking. So some people have had surgical removal of the tori, but they do grow back. So it's just bone that wants to grow. And you'll see it, like here you can see these radiopaque areas through here. That's all the mandibular tori. Here is images of the maxillary torus, and then you can see it in the intraoral image there. It's not as common to see it on the maxilla, on the palate, as it is in the mandible. You'll see it a lot more in the mandible. I need to take a picture of my maxillary buccal exostosis. I have crazy huge buccal exostosis. So I need to take a picture of that and stick it in this PowerPoint for next year. Retained root tip. So someone had an extraction and the root broke off and the doctor they didn't know and they just left it. So if you see molars missing, generally speaking, it's most often with molars missing. And then if you take an x-ray and there's a little floating root tip, then and oftentimes it doesn't have a problem unless it migrates to the top or gets a little infection around it or something. and Halloween. This is late because Halloween is past. I think they must have given this presentation sometimes before Halloween, but I don't think those teeth are real. Do you think that they just added all of that? I think they did. All right. Well, that's it, guys. 34 minutes. Not too bad.